Welcome to Oncology Unscripted. My name is Matt Spraker, a radiation oncologist in Denver, Colorado.
My name is Katie Coleman. I am a kidney cancer patient and patient advocate in Austin, Texas.
And my name is Julie Johnson, and I am a sarcoma patient and patient advocate in St. Louis, Missouri.
We're teaming up to meet in the middle for a candid and educational podcast about cancer that is intended for patients, doctors, and their teams. This show and our opinions are meant for general informational purposes and are not medical advice. We encourage you to reach out to your doctors to discuss your individual case. Thanks for listening. Now let's get on with the show. Welcome back to Oncology Unscripted. We have another great guest with us today. Very excited to introduce Dr. Shankar Siva. He is an expert in SABR or SBRT in the kidney cancer world, and we're going to talk all about that topic today. Maybe, Shankar, you could introduce yourself, tell us a little bit about your practice.
You can probably hear from my accent that I'm not from the US. So I practice in Melbourne, Australia, and in the centre called the Peter MacCallum Cancer Centre. We're one of the larger radiation oncology centres globally. So we treat over 7,000 patients per year with radiotherapy. And my particular interest, or one of them, my particular interest is in renal cell carcinoma and the intersection where radiotherapy can particularly help. So we've done a few trials in this space, and I'm very happy and very glad to be able to talk about radiation in the context of what it can offer for patients with kidney cancer.
Awesome. Thank you for joining us. So I think one of the first questions I have in talking about radiation for kidney cancer, this comes from even my own experience. I know when I was initially diagnosed a little over 4 years ago, I actually took quite a bit of a tailspin initially when I was diagnosed, because at the time, it was kind of when immunotherapy was really kind of starting to be used a lot more in kidney cancer. But when I was first diagnosed, the only treatments I had ever really heard of were chemotherapy and radiation. And I remember coming across everywhere I looked that radiation didn't work in kidney cancer. And so I was very nervous as a newly diagnosed patient, wondering kind of what my treatment options may be. I know the space has kind of evolved since then, especially over the past few years. And some of the trials you've been involved in shows that radiation can work in kidney cancer in some specific scenarios. So I was wondering if you can kind of touch on the trial that you did around kidney cancer with radiation and kind of what the results are from that, or how it's been shifting the landscape a little bit in what we think of for radiation for kidney cancer.
So absolutely. I mean, taking your own context, I wouldn't say that at all you were being naive and thinking that radiation was not an option in kidney cancer. Actually, traditionally, even for us, we as training as radiation oncologists, our teaching is that radiotherapy is not something to be used in renal cancer because it's not radiosensitive. So this is really largely because we've been using conventional radiotherapy in the past, and that when I mean conventional radiotherapy, that means many little doses, 2 gray per fraction, so many different days broken over many weeks of radiotherapy, so 5, 6, 7 weeks of daily treatment. This is not actually a very good strategy for kidney cancer, as we become aware that kidney cancer doesn't like these very small broken up doses of radiation, but giving larger doses per treatment of radiation is actually quite effective. So in the past, we had many trials that had shown us that in the context of patients presenting with a new kidney diagnosis and inside a kidney which hadn't spread anywhere else, that giving radiotherapy in this context, even after surgery, didn't help improve survival or patients living longer. It may have helped to reduce the risk of a cancer coming back locally, but no more than that. What's really changed the dial and moved the needle is the use of stereotactic body radiotherapy or stereotactic ablative body radiotherapy. So I use the other term SABR in my context. In Australia, that tends to be more common. So the use of SABR has really changed the needle in the conversation here. This is because this is very precise, high dose per treatment types of radiation that we know that kidney cancer actually has a really good response rate to. This has evolved over several trials that you alluded to. So we did do a bit of a review of the literature from the ISRS group. So this is the International Stereotactic Radiosurgery group that was published in Lancet Oncology in January of 2024. And at that time, there's been over a dozen prospective clinical trials in the context of primary kidney cancer and the use of SABR. Now, a dozen is actually a lot, because when we look at local therapies, even for surgery, when asking the question about what is a primary local therapy in surgery, there's actually not that many trials. There's a couple of randomized trials looking at partial nephrectomy versus total nephrectomy, but the actual investigation of a local therapy is very rare. There's not been any prospective trials up until last week for thermal ablation, and we have 12 in the context of radiotherapy. So actually the evidence base is reasonably strong in radiotherapy compared to other sites. So this type of radiotherapy has been all stereotactic radiation, or SABR, and overall the outcomes are pretty consistent. We are able to show really excellent local control rates from a kidney sparing perspective, because kidney function is particularly important in patients when we're trying to spare them future local treatments or make sure they don't end up on dialysis. Kidney sparing is pretty much comparable to one of the gold standards being partial nephrectomy, so only taking out part of the kidney. So this type of approach using SABR is really, really exciting, and actually from an evidence base, pretty robust. Our own trial was called Fast Track 2. This is a trial that, it stands for Focal Ablative Stereotactic Radiotherapy for Cancers of the Kidney, or Fast Track. We love first letter acronyms where I'm from, so that's what we tried to do. And this particular trial was a multi-centre trial that ran in 7 institutions across Australia and 1 institution in the Netherlands. And what we were able to show in the first of a kind multi-centre phase 2 trial is that we had an unprecedented local control rate. So at roughly 4 years follow-up, so 43 months median follow-up, the local control rate was 100%. In fact, no patient died of their cancer during these treatments. And importantly, the type of patients that we're treating in this trial were not patients who presented with an incidental small renal mass that really could have been left alone. 70% of the patients had already undergone active surveillance and had progressed prior to receiving treatment. So biologically, they were already showing kidney cancer that was aggressive. And the average tumour size was 4.6 centimetres. These weren't small renal masses, these were significant tumours. When we compare this to randomised trials in the surgical setting, for example, the famous EORTC Van Poppel study, the average tumour size in that context was only 3 centimetres. In a more recent Brazilian randomised partial nephrectomy versus radical nephrectomy trial, the average size was 3.5 centimetres. So we were treating bigger and more biologically aggressive tumours, but having unprecedented outcomes in terms of control rates and distant failure rates and cancer-specific survival. So that's really, really exciting. And that paper was published in Lancet Oncology in March of 2024.
Do you? Oh, sorry. Go ahead, Matt.
Can I just jump in? I just wanted to say, kind of point out something you said in passing, because I think this might not be sort of front of mind for a lot of patients. But one thing that's we see a lot in oncology is, like, we have a standard of care that's been around for a very long time. And so surgery, you kind of mentioned, that is not sort of tested in randomized trial fashion the way that many therapies are now, maybe primarily because this has been going on for so long. Surgery is one of the oldest cancer therapies we know about, and it's had good outcomes, at least in our clinics, like anecdotally to the doctors using it. And so it's sort of an incumbent. And one of the, I think, points you're making is that we started from a place where radiation is something that was previously thought not to work by the whole world of oncology. And what you're arguing here is that we now have multiple studies that all show similarly that as long as you use the SABR approach, the one that is the modern era approach of this, it works really, really well and on par with the outcomes that you might see in the few trials that have evaluated therapies that we're using all the time, such as surgery.
So I think that's a really important point. It's kind of the tyranny that we have of having a primacy of one certain type of treatment. And that's fair enough, because, as you said, surgery's been around for hundreds of years. But actually, radiotherapy has been around for over 100 years, 110 years old now in terms of therapeutic radiation. And when we're talking about systemic therapies, they've really only been on the scene for about 50 years or so. So we've had a lot of time to evolve, and SABR is the state of the art of what we have at the moment. It's revolutionary in terms of the technology, the precision, the ability to deliver meaningful doses that is tumoricidal and able to actually control cancer really well. The issue is where do we put this on the pedestal when we're comparing treatment options? Unfortunately, reality is that radiotherapy, it only attracts less than 1% of the global budget in terms of funding for trials, and therefore research, when we're talking about we need randomized phase 3 trials to move the needle, it's pretty unrealistic in the context of radiation treatment. Radiotherapy, at least in Australia, only costs 9 cents in the dollar in terms of the amount of funding that it's applied or cost to the general healthcare. We have a universal healthcare system, so it only costs 9 cents in the dollar. Yet we use it in over 50% of cancer cures, and we're using it in most patients, in fact, who are receiving some type of cancer therapy will come across radiation treatment overall. So yeah, I think the bar is set a little bit high for us and a bit unrealistically, and in a sense, guidelines are starting to reflect this too. When we're talking about SABR for primary kidney cancer, it is actually in the guidelines for NCCN. It's going to be in the new EAU guidelines. It's in French guidelines. So over the last handful of years, I think we have recognised these outcomes are too hard to ignore and really should be allowed in the standard treatment paradigm. So that's an exciting space to be in.
Yeah, and I think it's really, just to drive the point home, I don't know that it's, I mean, in real life, when a patient is going to clinic, like Katie, like when you did, it's not, you certainly want to be able to compare therapies when that option is available. But the message that I'm really hearing is that, like, patients can be reassured that SABR is an option they should be aware of. And if it's an option that makes sense for their care, it is a very good evidence-based option, right? There's now a lot of data to support that it's a very effective treatment. We could talk probably for hours about how it should stack up against other treatments, but at the end of the day, it's one that is now kind of on the scene and there.
100%. And I think eventually the goal would be to have a randomized trial versus the standard of care, which is partial nephrectomy or radical nephrectomy. I think from a patient perspective, having only part of the kidney out is much more attractive rather than having the whole kidney taken out. But if we could do a trial like that, I think that'd be really ambitious. But history will tell us there's a graveyard of trials that are trying to compare local modalities like this. So, I'm a little bit trepidatious about stepping in that field, but maybe this is the way to move forward in the future to answer this question.
So one of the things that we've talked about on previous podcasts here is how patients can advocate for themselves. And one of the hardest parts of advocating as a patient is even knowing what to advocate for, like even knowing what your options are. We did an episode early on talking about tumor boards. I know when my case went to a tumor board, I had no idea what a tumor board was. And now several years into my diagnosis, I know if something came up, I know that I would look at several other options. But when you just go to one specialist, especially here in the States, it's a little bit harder to know what options are available to you. And so I think sharing this information widely is really helpful to help patients be able to advocate for themselves and ask if their context and their scenario warrants looking at these kinds of treatments. And then the other thing that I just have a genuine question from a patient perspective is, I think the other piece is patients knowing the right thing to ask for. So I think the term that is often heard of is SBRT. And I think we've talked about this on our Radiation 101 podcast, but using the different terms for something similar, I think can make patients not sure like which treatment is which and what they should be asking for. So can you touch a little bit on if there is a difference between SBRT or SABR, or are they just really just difference in terms to help patients kind of understand when they hear these terms, if they should be looking into different avenues at all?
Yeah, you touched on some really important points there. So from a patient advocacy perspective, I got to highly commend you for this podcast. This is super powerful to be able to get some reach into spaces where patients might not find it very easy to navigate the medical system, and having some kind of lay description of what we're talking about is super helpful. So yeah, work like you're doing, Katie, and on this podcast is really, really important for people to understand what the options are. But when we're talking about the same issues that you're describing in the US, we find the same things. And when a patient comes to see a clinician as a first port of call, you often build some rapport and empathy with that clinician, and therefore it may take on face value the options presented to you. And I think that's reasonable. Building up trust and is important. But to become aware of different options and doing some reading, it can be confusing having different terminology. SBRT, SABR, they're exactly the same thing, no difference. There's actually other terms that also become a bit confusing. So stereotactic radiosurgery or SRS, SABR, SBRT. For me, these are all interchangeable. There are, of course, some nuances that we would think about from a practicing specialist, but from a patient point of view, I think they're all interchangeable. The issue is, whether you even put it as a more broader category, like I would probably lump it as, is radiation an option for me? Because, surgery, it's even more difficult to say whether a partial nephrectomy or radical nephrectomy, even these terms can be somewhat confusing. And from a drug therapy point of view, there's broad categories that are, people are quite aware of, like immunotherapy and chemotherapy. But this is part of the things that we've got to explain to patients when they're in some of the most vulnerable moments. What is the difference between a TKI or a tablet form of chemotherapy? What is the difference between an immunotherapy or standard chemotherapy? So, I would just lump it in basically, there's the sword, there's the fire, and there's poison. Wear the fire bit, and we can go on the nuance from there.
Yeah, that's awesome. That's very helpful context. And I think that'll be helpful as we kind of continue our discussions too, if any patients are listening and trying to figure out SBRT, SABR, kind of that we're all talking about the same category there. One of the other follow-up questions that I had is, do you think that the communication about these options through even social media platforms and kind of more modern technology has helped the awareness and help get them into the guidelines because it gets more people talking about them, more might be highlighted at some conferences? I'm not quite sure what the dynamics look like there, but I will say I commend you on your graphics that I've seen in several places, that when it's shared, it's eye-catching, and it's very easy to understand what it is, even from a patient standpoint, to where it makes it much more approachable to both share that information, but also to dive in and try to understand what the trial's about. And so I'm curious your perspective on if you think that helps and if that's a strategy to try to help communicate the science.
Oh, thanks, Katie. That makes me feel really warm in the heart because, I spend a lot of time with the kind of jazz hand stuff, the titles and the slides. And sometimes you wonder, whether that's just masking science, but, I'll do whatever it takes. In terms of what it means from a scientific and guideline and perspective, and I'm not sure, maybe you could tell me like what the impact is of having these kind of communications with social media, etc. I kind of still feel that, and maybe I'm not getting the right perspective, but I kind of still feel that these guidelines are chaired by, the wizards, the wise and old tribesmen of the communities who may not be looking at social media and may not have the ear of advocates. So I don't know, maybe you can tell me, do you think it's helping?
Yeah, I mean, I personally, on the kidney cancer space, think it's helping. I mean, I knew who you were because I've followed you on Twitter or X, whatever we call it these days. And I saw this trial information, and I saw it reshared on other platforms and either other people sharing the graphic of like comparing the differences between surgery, ablation, and radiation. And I think it makes it so much more approachable. I'll say from a patient perspective, it's more approachable to be able to take something like that of like, oh, I saw this image. Can you help explain this to me? Even if the technology would be something that maybe earlier in my diagnosis, I might not understand the nuance, but behind the science of it, it gives me something tangible to start that conversation with my physician. And then as an advocate, I'll say those things make it much easier to share that information with others because it's 10 times easier to point somebody towards a graphic or a tutorial or something like that than it is to point them to the NCCN guidelines. I still point them to the NCCN guidelines, but they are looking at the graphics and they're looking at the other things to help give them that high-level summary. So one of the questions I had I know you quoted the surgery. There was a couple trials that you mentioned that were comparing surgery, and I think they were like 3 centimeters, 3.5 centimeters. And you mentioned that the outcomes using radiation and SABR were comparable to those. I was wondering what the local control rate was for those studies. I know you mentioned the local control rate was near 100% or 100% in the radiation. Do you know what that was in surgery for the same kind of, I know it's kind of hard to compare one-to-one. That's kind of what we are talking about here, but getting in the same ballpark.
Yes, I think the local control rates were excellent. They're above 95% in these smaller renal masses. So when we talk about a smaller renal mass, we mean tumors less than 4 centimeters in size. So on average, the control rates are really good. Also, when we're talking about taking the whole kidney out, having a local failure is pretty unusual because, the kidney's completely out. Whereas when you're trying to spare kidney function, that's a little bit higher proportion of those kind of things happen. Actually, very recently, hot off the press in February of this year in the Lancet Oncology, there was a comparison, a meta-analysis between thermal ablation and stereotactic radiotherapy that was published in February with the it's a Canadian group from Ontario. But this publication did compare some of the outcomes between thermal ablation and radiation. And certainly the size for stereotactic radiotherapy trials is much bigger than the cryoablation, microwave, and radiofrequency ablation trials. But the control rates at 5 years are actually very comparable, if not a little bit better for SABR than it is for the other treatments. And this is in the context of, although SABR being a newer treatment, it has more prospective clinical trials, and we're treating larger tumors with older patients and less robust kidney function. So, I think that's the way things start. When you have a new technology, you always try to make sure that we are testing in patients that have limited options. But now I think we're getting to the stage where this might be a preferred option in many patients when we're considering comparing thermal ablation particularly. And then for patients who are clearly surgical candidates, I still think a partial nephrectomy is a standard of care. But at least in the circles that I'm working in, when a patient can't safely have a partial nephrectomy, or maybe it's technically unclear whether it's a partial nephrectomy or it needs to be a total kidney coming out, then they might suggest, look, why don't we try SABR first, spare this patient's kidney, and then we can always save surgery as a salvage option down the track.
Yeah, so I'd love to explore that area a little bit more with you as well too, because I have some questions. I'm not quite sure you'll have the answers to them in this context, given that it's mainly been tried in an older demographic. But would love to hear your thoughts on the future aims for some of this. I know as a patient myself, before I had surgery, one of my biggest fears with having cancer was actually having surgery. And it was just about going under general anesthesia was a lot of the fear for that. And now that I've gone through that, it's kind of less of a hurdle for me. But especially for younger patients who may not have ever gone through a surgery before, there's a significant burden there as far as wanting to or trying to get past that fear that kind of comes out of going through a surgery, and especially when they might be taking an entire kidney and the complications that may come from that. I know there's also, from hearing from patients who are diagnosed with small renal masses, I know that those are more common in younger patients. They might get picked up incidentally for something else. And I know there's been a movement in some areas to do active surveillance for masses under 3 centimeters because they're very unlikely to spread under that size for most of the subtypes. However, I also know that patients have a lot of anxiety over just leaving a tumor there, but they also might have that equal balance of they don't want to go through surgery because they have anxiety over surgery. And so curious if you see anything in the future to maybe treating those patients with radiation to those tumors, those small renal masses in the future as an option of they don't have to undergo surgery in that standpoint, and then they cannot also be acting instead of having to wait in those scenarios where they might be more active surveillance.
That's a really good question, and I think as much as I'm a proponent for stereotactic radiotherapy, I don't think we're there yet in this kind of context. Maybe in the future, perhaps we can think about this as an approach for sparing a general anaesthetic in a clearly fit and younger patients, but. Well, we have 10-year data on SBRT and SABR, but we don't have 20-year data and that kind of longer term outcomes. So I'd be pretty cautious in a younger patient, perhaps in their 40s, for example, to consider this as an approach rather than a surgical approach when it's required. Going back to the active surveillance question, though, that's a really good option. And that's because, as you mentioned, those tumors are less than 3 centimeters in size, even up to 3.5, 4 centimeters in size. The metastatic potential is pretty much non-existent at smaller renal masses, but when we're getting to that 3 to 4 centimeter mark, then it becomes evident, but it's still quite low. And so slow growth rate over time and a small renal mass, it's very reasonable to undergo an active surveillance approach and then consider a local therapy down the track. Now, the issue for us is how to communicate this with patients effectively and, make sure that both of us are on the same page. It's a bilateral communication. Part of it has to do with the way, how relaxed you as a clinician trying to explain this to the patient is as well, and trying to reinforce that the idea is, anything that we do to you will make you feel worse than you are right now, and you may not need anything for a period of years, for example. And it's a complicated situation. I think we're doing it better in some cancers, for example, early stage prostate cancer, low-grade prostate cancer, which is very common. We're getting better at this conversation that you don't need anything more than close watching, at least in the Australian setting. But for kidney cancer, it's the same kind of thing. It's just trying to communicate this and make sure that everybody's on the same page from that perspective, from either a treatment or active surveillance approach.
Yeah, I personally feel like in the kidney cancer space, a lot of that, I do think that communication and communicating things very simply, like even going back to the kind of graphics that you put out there and communicating these things, I think they're really powerful because I know when I was initially diagnosed, you hear the word cancer and you automatically assume the worst. And I had no idea how to even gauge tumor size. I had a 12 centimeter tumor, so I had a very large tumor and several in my liver as well. And so I did have a large amount of disease, but I had no idea how to tell if 3 centimeters was small, like, and what that risk is. So in the kidney cancer space, one thing that I feel like we could probably do better as a community in general is helping communicate more around those small renal masses and helping show that they're very, very unlikely to spread. But I also do know as a patient, some of that takes some time. I know the idea of active surveillance. So initially surgery wasn't an option for me, even though I was stage 4. And the idea of leaving the cancer behind was unfathomable for me. Wow, I can't say that word. But it was like, I could not imagine leaving cancer behind. And that came from just kind of natural society views on cancer and feeling like it would just go unchecked and progress like crazy. And now being several years into it, after having surgery and going through everything that I've gone through, there's still a few spots in my liver that we watch. They used to think they were suspicious for metastatic disease. They've been stable for multiple years, so now they think that they are most likely benign, which is why I am called no active cancer now. But I truly, truly value being on active surveillance now. We could go in and try to ablate those spots, but I've had spots ablated before. We missed a couple of them slightly. And I also know that they weren't growing. And so like, I know what it's like to experience being on treatment or going through these procedures and know that there is both an emotional toll and a physical toll that it takes on your body. And so active surveillance can be a really good option for patients. I just think that the communication around that is something that probably needs to come a little ways. And I'm curious how radiation will end up fitting into that scenario too, if you go from an active surveillance to then a localized treatment that I think it's fantastic that a lot of patients don't end up with side effects kind of initially after the treatment, and they can kind of go back to their normal life for the most part, and their normal activities much faster than they would be able to from surgery. And so I think it's really great as a patient to be able to know that these options exist so that you can decide what's best for you. Maybe you want a surgical route instead, or have that discussion, but even knowing that the options exist, I think is a great direction to be able to have for patients.
Yeah, I mean, thank you for sharing that story. That's really compelling, and I guess that kind of illustrates a lot of this point. When we're talking about a 3 centimeter tumor, it doesn't help when you're saying you have a golf ball sized tumor and we're going to watch it, right? Because that sounds terrible. But that's what we're talking about. We're talking about a 3 centimeter tumor that may or may not be something that has the ability to spread. And when we're talking about different treatments, yes, SABR, as you mentioned, it's really straightforward from a patient's perspective. From our perspective, when we're talking about primary kidney cancer, we're talking either about 1 session of SABR or 3 sessions of SABR. That's our protocol that we use. So what that means from a patient's perspective is they come in once for a 1 hour treatment where they lie flat on the bed. The beams are only on for maybe 10 minutes. Then they hop off, they go home, they drive themselves home, they have dinner with their family, and everything's back to normal. And that's it. That's all they're looking at. But the communication point becomes challenging, not at the time of treatment, because not everybody, but virtually everybody finds it a really straightforward treatment process. It's what happens afterwards when you're watching these tumors. So what I need to do to explain to a patient point of view is when this is not surgery. We're not reaching in and yanking out a piece of your kidney and a tumor along with it. We're talking about a very focused, precise type of radiation that's going to take months for this tumor to shrink and to scar up. And we're always going to see something on these scans, but what it is just dead tumor. And it's always going to be a bit of a scar area that we can see down the track. But communicating this expectation that we're expecting to continue to see ongoing shrinkage even years after the treatment, patients need to know this up front. Otherwise, the expectations aren't aligned and you don't know what to expect. Same with active surveillance. If you've got a small tumor, you really need to know that we could be watching this for years, and that's normal and that's perfectly okay. But if the patient is not willing to sustain this kind of anxiety around it, maybe active surveillance is not the best option for them. So really got to be clear on the communication front.
Yeah, I think you make a really good point too about communicating back with them about what to expect in the future, because I think that's really important, not just for where they get their treatment, but I know as a patient, I've been on several different insurance plans, and here in the States, that usually means I need to see a different provider. I'm very thankful that I've been able to consolidate my medical care. It's largely because I won't take a job or something that makes my insurance change. But when it comes to, I know for me, like I had ablations, microwave ablations, and very similarly to what you described with radiation, there's always spots that now are on my scans. And so if somebody completely new who did not have my history saw my liver, they might wonder kind of what those spots are. And so I think I'm glad you highlighted that, because I think it's important that patients not only know what the treatment is, but also how it affects their body, so that if they get a scan down the line, even if it's like in an emergent scenario and something is still marked on their scan, they might know that that's an expected thing, and then to follow up with care to just obviously make sure in all those scenarios. But I think that's really important to help communicate as well too.
In the United States, I don't know if this is true for Australia, but now patients have access to their radiology reads pretty rapidly after the scan is completed. This is something that's being worked out, and I know hospital systems, like some have it turned off, and it's different time periods, so it's not the same for everyone. But one of the things I spend so much time doing over the last couple of years is basically telling patients that if they're going to read their report, to, in the back of their mind, keep it in mind that they need to review it with one of their oncologists, especially one that is aware of the treatments they've had. Because SABR, it's consistently misinterpreted, or a better way to put it is if the doctor reading the radiology scan is putting out a report and they don't know that some somebody had treatment. It may actually influence the language that they use. And so I usually kind of put that in patients' minds right when I meet them as just sort of a warning for the future, that if they see something they don't like, to come and talk to one of us about it, so that we can go through with them and kind of talk about how to interpret changes after SABR, which is a big challenge in general.
It's a very good point. Scanxiety is real, which is what we're going to call it. But I think it's an emergent thing happening in Australia. I don't think it's as common that a patient will come to me having already read the scan report. It's becoming more common, but we're facing the same issues here. And I think you're right. It's more the issue with the reporting radiologists. They're very busy. They may not know what local treatment's been given or what kind of systemic treatment's been given. They may not even be up to date with what is the difference between an immunotherapy expected response versus a TKI versus SABR or radiosurgery. And it's very difficult for a person who's reading scans to know all this. So, yeah, I think we'll stick to hanging out with our kangaroos and koalas rather than trying to figure this out down here.
So one question I have along the lines, I know you said when we were talking about if this would ever be an option for those smaller renal masses or in patients that are a little bit younger and diagnosed who kind of are fit and could undergo surgery. Because one of the questions I had, which I think you touched on, is that there's not studies 20 years out. And I know radiation has more late effects that can happen from the radiation. So I was curious if there are any studies or any information that shows, for example, if you did a local therapy on a younger patient, are there any risks we know secondary cancers from radiation usually come many years later. Are there any risks of that causing any damage that might cause like a secondary tumor in the kidney? Or have there been any studies that kind of track that to see if anything develops more from the late effects?
Yeah, very good question. I just wanted to clarify one point that you mentioned, whether SABR would be an option for a small renal mass. Actually, it's a great option. It's just that when a patient requires treatment, that's a first-line option in my mind. If a patient requires treatment and they may be a little bit risky from a surgical point of view, I would put SABR as a first-line treatment option. And for me, it's preferable to thermal ablation based on the evidence that we have to date. But when we're talking about late effects, particularly with a younger patient, that's the great unknown. And I don't think we have that long-term data, 20-year data out for late effects from these very high-dose radiation treatments in the kidney. We can extrapolate from other cancer sites. For example, prostate cancer, there's been SBRT or SABR around for a very long time. But these are, somewhat bigger tumors in the kidney often. We mentioned golf ball size, but golf ball size are bigger. It's quite a bit different. So the short answer is I don't know, and I'm not super comfortable in a clearly fit and very healthy patient who has a 30-year window of survival, just from other reasons, 30, 40, 50 years. I'm not sure that patient would be best suited with radiation over surgery. Because I don't have that long-term data at the moment. But for example, if we have a few medical issues, for example, that might make that more likely at risk of dialysis or background kidney dysfunction already, or if there's some medical issues, we're on blood thinners or having cardiac issues, this is a type of patient that might do better with radiation, in fact, than with a surgical approach. So it has to be a nuanced discussion and a multidisciplinary team discussion to get this across the line.
Are there any differences in the location of where the tumor is? So, for example, if there might be a tumor that's closer to like a one of the arteries in the kidney or more in the center of the kidney that might be more difficult to have a surgical approach on, is that something that radiation can usually treat in those scenarios? Or is that something that you still run into the same limitations and it becomes more risky than surgery in those scenarios?
It's a great question. And in fact, I think this is a reason why radiotherapy has really taken off, at least locally in terms of uptake over the last 10 years or so, because it's quite complementary to surgery in that kind of context, in terms of that central pelvic location. So the kidney has different locations. The pelvis just means centrally, and centrally means it's close to renal vessels, renal artery, renal vein, and close also to the ureter. This can be really challenging from a surgical perspective to get a partial nephrectomy or just taking out part of the kidney. There's renal complexity scores that the surgeons use that can help define how difficult it's going to be to do a partial nephrectomy. And the kind of tumor you're describing would be more challenging. And in fact, this is why SABR, I think, is a really good option in these areas, because we don't have the same issues that an alternative like thermal ablation or partial nephrectomy might have. So the renal vessels can act as heat sinks for thermal ablation. They can draw away the thermal energy, so that from a cryoablation perspective, you can draw away the cooling effect. From a radiofrequency or microwave, you can draw away the heat energy to those areas. And so these kind of centrally located tumors are known to be less affected with thermal ablation. Also, the ureter, which is the piping that gets rid of the urine and leads towards the bladder, this area can also be strictured or scarred up with thermal ablation, whereas we don't see that same issue with stereotactic radiotherapy. So these centrally located endophytics, in other words, tumors that are predominantly inside the kidney rather than outside, are kind of perfect candidates for SABR. And this is partially the reason that we've been using it more commonly. And certainly in my local practice, we've seen that the rates of, or the number of patients we're treating with SABR has kind of exponentially climbed in the last handful of years.
I think one feature of radiation that's worth pointing out that's not immediately apparent to a lot of people is that the field in general has done a lot of work to make very accurate what we call dosimetry. So this is like the amount of dose you're giving and where it lands in somebody's body. And we do that with what I would argue is the best accuracy in all of medicine for local therapies. We really demand a lot from our physics colleagues to make these therapies like that. So you mentioned like there's less of a risk of scarring the ureter. It's not that the radiation can't be harmful to it. There are examples in the literature, like in other cancers that I can think of, where we've had to pay close attention to doses around that structure to make sure we don't scar it in the long term. But the reason that we don't see that is because there is significant work put in up front when patients are planned to get radiation, and we can be very accurate in where these doses land with people. And I think, if we talk about other topics in the future, this will play out. I think it's one advantage that radiotherapy has as a modality over some of the other mechanical therapies like microwave ablation or cryotherapy, is that you can really accurately predict where the dose is going to go, and then when you actually deliver it, it lands where you predicted it's going to land. And I think we've become very good at that. And SABR as a technique really like leverages that feature maximally, in my opinion.
Yeah, I agree with that. And in terms of from a teaching perspective as well, it's partly having protocols, things like Fast Track 2. The protocol is in the supplement there. People can just read it. The radiation oncologists, our colleagues, can read it. And we've done a lot of efforts actually in our own group with something called IROC, which is the International Radiosurgery Oncology Consortium for the Kidney. This is a group that's an international group that we're kind of harmonizing some of our techniques and approaches along the way. And right now, IROC has over 20 active sites internationally. We're opening Japan and India pretty soon, and hopefully Israel as well. So this is across North America, Australia, and Europe. And we already have a prospective registry at this point that's collected close to 200 patients. So moving forward, we're hoping to have prospective large volume data that can kind of define granularity between different treatment approaches, different radiation machines, different jurisdictions, and different patient populations as well. And that's going to really help us, I think, in the future, kind of get to the nitty-gritty of these kind of technical questions that we're asking about where things go in terms of dose and what these organs at risk are, and what we need to be careful about in the future.
So are you also tracking by subtype? One of the questions I had is SABR more effective in certain subtypes of kidney cancer versus the other types, or is it kind of just effective across the board equally for all types? And is that something that you might be tracking with the IROC data as well?
That's an excellent question. In fact, we might send the paper out for you to be a reviewer if we can. But we've just looked at that data, in fact, from IROC, and this is one of the largest series that we have differentiating between clear cell and non-clear cell. So, over 200 patients that were included in this registry. And this is differentiating between the subgroup of non-clear cell, which is not as common, as we know, versus clear cell kidney cancer. Bit of a spoiler alert, but basically the control rates are excellent in both groups, above 95% control rates, actually significantly above. And some of the recurrence rates in terms of distant recurrence, we know that clear cell kidney cancer, the more common type, tends to be a little bit more aggressive in terms of recurrence rates. So we saw that distantly, where tumours might come back in, say, the lungs or the bones sometime down the track, but not significantly so. So just a little bit more so than other types of kidney cancer like papillary RCC. So, the upshot's going to be that actually SABR works just as well in both types, but just keep an eye out for this publication, hopefully coming up in the next handful of months. I might make a gratuitous plug while I'm here as well. IROC was graciously funded from a philanthropist from the Low Family Foundation from Hong Kong. We're actually recruiting in this prospective registry a lot quicker than we expected, and we're going to run out of cash sometime next year. So we're on the hunt for either philanthropic or industry funding right now. So if you know somebody, let us know.
I think it's excellent that you're tracking that, and it's super important to have those registries that are tracking that across the different populations instead of just one institution. A couple follow-up questions there. One, did you track that in chromophobe kidney cancer at all? Did you have any patients that had chromophobe to know what their response was compared to the others?
Yeah, so we did. As you may argue this, but often we're lumpers and splitters in medicine, and we lumped non-clear cell together because chromophobe was only a small proportion. So of the 44 non-clear cell chromophobe, I can't remember the proportion, but it's only a handful. So from a powering statistical perspective, it's not really clear to be able to say there's a difference. So the short answer is I don't know to that granular detail, no.
Okay. Yeah. So one of the reasons why I was curious on that, and definitely this is more exploratory, so please correct me if I'm wrong here, but I'm very curious. I do a lot of advocating for chromophobe kidney cancer because I have a nonprofit for chromophobe kidney cancer. But I feel like I've heard from our other episodes that ferroptosis is one of the routes that radiation often impacts for the cell death for when you're using radiation. And I know that chromophobe kidney cancer, for example, is more susceptible to ferroptosis than the other subtypes. And so I'd be very curious I was curious from a perspective of if that might be involved at all, if it could be more successful in chromophobe. And branching, I know there's no data for this currently. So this is kind of the exploratory aspect. I'd be very curious. Chromophobe patients often have disease that spreads to the liver in more of a localized fashion. Of that might be the only organ that it spreads to. And I know SABR can also be used in the organ or in the liver. So I'd be very curious if there's ever any future studies exploring treating more oligometastatic, I always mess up that word, disease that might have spread only to one other organ, and maybe exploring those in some of the subtypes. That's, again, kind of getting more into a splitting scenario, but for these stage 4 patients that don't have a lot of options, if there would be any biological rationale ever worth exploring for those that are not localized, but not kind of widespread disease.
Yeah, so that's a really interesting question. I don't think I have the answers to the in-depth biological questions, so I might defer that. But I might talk about the point you mentioned about oligometastatic disease and those limited spread. So we certainly use SABR as an approach in oligometastatic disease, and it's very, very effective. And we've conducted trials. There are trials in the US as well and in Europe that have looked at all the treatment of oligometastatic or limited spread of kidney cancer. Now, what that means in terms of limited spread, that's also up for argument. For example, a lot of people say up to 5 spots of disease that spread beyond the kidney, but even the definition there is a little bit variable. So I think, in my head, I kind of put it in 2 buckets. So one is, of course, it's, we have to determine whether the systemic options are great, and some of these non-clear cell cancers, the systemic options are great, and therefore you might lean towards local treatments like SABR. And so there's the other group, the 2 groups I kind of lump this into is this low volume and kind of disease-free interval from the primary to the recurrence of the disease is long, and it's kind of this favorable. There's a risk categorization you use in kidney cancer. It's kind of like this favorable category, low volume category. This type of patient actually using SABR instead of or in lieu of systemic therapy is a really attractive approach. So this kind of patient might present with 1 or 2 spots, and it's been a couple of years since the surgery and they're doing well, and you have one option of giving lifelong systemic therapy, which can have cumulative side effects that build up over a long period of time, can be financially quite toxic as well, and can lead to other medical problems too. Or you can defer that. You give them very effective spot welding radiation that takes care of those spots, and you may defer a systemic therapy for quite some time. So in that kind of low volume context, there's been a couple of trials that are really interesting. They both come out of Texas, from MD Anderson and UT Southwestern, that are looked at using radiation in lieu of or instead of systemic therapy. And on average, the average patient buys about at least around about a year, without needing systemic therapy with that approach. The other approach that we used is in a clinical trial that we conducted in Australia at Peter Mac and in a centre in Brisbane called the Princess Alexandra Hospital. This was a study looking at higher volume, bit more aggressive, but still up to 5 spots. So these patients had either had their cancer present with distant disease at the time of presentation, or had multiple spots, on average 3 or more spots of cancer when they came to treatment. And this, we combined a short course of stereotactic radiotherapy, so 1 treatment, in fact, very focused, and a short course of immunotherapy, so pembrolizumab, 8 cycles, 6 months. And then we saw what happened, and we waited. And actually, patients did really well from this approach as well. In fact, had long-term survival, and some patients are still alive with that disease 5, 6, 7 years later. I see them in clinic. So, these are 2 approaches in my mind. Those patients have got good biology that we may be able to defer lifelong systemic therapy for as long as possible. And then there's the other bucket where it's not so good biology, but it's still a limited spread from the primary. And we might want to combine a short course of radiation treatment, SABR, and systemic therapy, and then see what happens, because these patients are unlikely to miss the opportunity for this drug therapy when they need it. But at least we can spare these ongoing long-term side effects and potential financial toxicity as well, by giving them a bit of a break or a holiday.
Yeah, I really appreciate the context around that, because as we're talking around patients advocating for themselves as well too, it's one thing to be aware of the treatments, but then also trying to be aware of how to interpret your own disease in the context of that when you're talking with your physician about it. You might so I think it was very helpful to hear you explain the context, especially for listeners as well too, of when that might be looked at more often, of kind of the slower spreading disease, or when you might have a little bit more time. Because I know one thing that comes up a lot in patient community is you hear about a really great option that somebody might have had a really good outcome from. I feel like I unfortunately end up kind of on the other end of that sometimes, because I had such a rare cancer and I had a very, very aggressive surgery that a lot of people think, okay, if she had that, I can have the same thing and we'll have the same outcome. Whereas my case is very, very unique. I had good biology really probably on my side for that. And so it's important to understand the context. And so if a patient might have a really aggressive cancer that's spreading very quickly, knowing that context ahead of time when you head into those conversations with your physician, I feel like will help patients not feel like their clinician isn't sharing an option with them, but they understand why that is not an option for them and why another route might be more helpful, or when they might have lower disease spread, why that's helpful too.
Can I add to that as well? It's not only deciding about whether local treatment is a good option in this setting, it's kind of deciding between which local treatment to use. So, for example, if we're thinking about surgery versus SABR in this kind of context, if someone comes back with a single spot in their lungs several years later, there is a potential that this is not kidney cancer. It might be a lung cancer. And in fact, surgery might be a good option to be able to understand the tissue that we have available and make sure that it is really what we think it is. Whereas, sometimes the spots of cancer are very difficult to locate. They need a big operation to take out, and SABR might be a really good option. So lung is a common site of spread from kidney cancer. Another very common site of spread from kidney cancer is bone. And this is something that it's much better suited to SABR rather than a big operation that can be quite morbid when we're talking about bony spots. So this kind of context about the local therapy is important too, but there's one other area that's really important in that kind of oligometastatic space, which I think radiation has a very unique and I think it's a tier 1 type of treatment for, and that's in those patients that we called oligoprogression. Now, this is kind of a different context. It's a patient who is having a good response to systemic therapy, their first line, for example, of systemic therapy, and then one or two spots might go rogue. They might escape resistance from this otherwise effective drug therapy and start growing. And this type of scenario is where radiation comes into its own, because SABR, by and large, does not interrupt the systemic therapy. The systemic therapy is really important. It's controlling other sites of disease. But SABR, we know, is extremely locally effective, but can also either synergize with immunotherapy or potentially make sure that the patients stay on their tablet form of TKI therapy or immunotherapy. None of this needs to be interrupted. And it's a good way of keeping that patient on that same systemic therapy for longer. There's actually been a couple of trials that have been done in this space. So there's prospective evidence, clinical trial evidence. One's from Canada, one's from Texas. And this looked at how much time you can buy when a patient is presenting with oligoprogression, so a couple of spots going rogue, with the use of SABR. And on average, this is somewhere around about 10 months. So you imagine that you have a cancer that's obviously not responding to the drug therapy, and the patient is starting to have cancer that's growing. And you can give a very easy treatment, even a handful of sessions in a radiotherapy department, and you can keep going on that drug therapy that you're tolerating really well and doing well for all other sites of disease for a further 10 months on average. That to me is quite a compelling case, and we have strong evidence in that setting, at least from a local therapy perspective, to suggest that's an approach. If you're choosing a local therapy, I think radiation is the best choice in that setting.
Yeah, that's fantastic information as well, too. I know early in my diagnosis, when I didn't really know anything about cancer, I kind of thought you were on one treatment and it either worked or didn't work, and you could be cured or not. And now that I've learned a lot more, I know that cancer mutates and you often become resistant to treatment. So anything that you can kind of prolong that window while you're on that treatment. Even as we've listened here, as we started off the podcast, I mentioned how when I was initially diagnosed, it's kind of widely accepted that radiation didn't work in kidney cancer. And we're just a few years later, and that conversation is really changing. And so a lot of times it can be about kicking that can down the road as long as you can for more developments and more treatments to come along. So I think that's fantastic context to hear and know about as well, too.
It's worth saying we're learning with you, or we're all learning together, because there's no question that like this is the conversation has changed in my own clinics, just out in the community, even over the last few years. This idea of using SABR as a oligo progressive treatment, or a treatment to get more time, kick the can down the road on a systemic therapy or delay a systemic therapy, that's becoming very attractive to oncologists. And it's something that I did not hear much about when I was in training. It's something that's more recent for sure.
Well, I think we're kind of at time here, and I appreciate all the time that you've given us and all of the answers for all the questions. I think this is going to be really great for our community to learn about and to follow as it continues to develop as well too, and see where the more long-term findings end up for kidney cancer as well too. So thank you for all the work that you're doing. And I know you've spearheaded a lot of this and really helped make an impact in the kidney cancer space for this. So thank you for that. And then thank you for joining us for the podcast as well too.
Thank you very much, Katie and Matt. And I must say, I've listened to a few of your podcasts. You're doing a great job. This is really important work that you're doing. So, and I think hopefully that from the community perspective, patients can turn to this as a reference point to understand a little bit about where radiation fits in the role for kidney cancer. So thanks for having me on.
Thanks a lot.